Okay, so here's this great case of this guy who cannot flex or extend his toe on a very minimal trauma. And when we were in class, we were looking at the complex. We were understanding the anatomy. Just to quickly review the sesamoid complex, intersesamoidal ligament. Remember that there are accessory and then proper collateral ligaments on either side. What happens at the dorsal hood is that the sagittal bands will connect through the dorsal capsule and the complex would be complete. We were looking for how the extensor hallucis and the digitorum and the extensor hallucis brevis, so the longus and brevis interact, and the brevis is supposed to attach to the proximal phalangeal base at the dorsal aspect of the great toe. And let's just go to this where we can see some of this on the T1. We can see the extensor hallucis longus getting to the base of the distal phalanx, and we expect the brevis to attach to the base of the proximal phalanx. Looking at it on T2 weighted images, getting to the area of interest, we can see that extensor hallucis longus, and now we're looking for the brevis to attach here and here. We see that there's a good amount of synovitis in this location. As we move towards this is the medial side, we can see that it may be attaching on the capsule, and on the lateral side, we see the synovitis in this location. I also see this here, and I'm not sure what to make of that. I cannot see that on the T1 weighted images. That is not something that's coming out, so that may be an artifact, or it may be the resolution of the imaging is something that I can't define what it is. Looking at what I can see on the T2 imaging, I can see my extensor hallucis longus, the region of the brevis in this location, and then what we're coming into is where this dorsal hood is attaching to the sagittal bands. So what I see the most of is that the sagittal band on the fibular side is sprained and poorly defined. I see that the collateral ligament attaches and the sagittal band is sprained where it's supposed to come around that complex. On this side, I see that there's actually some bone marrow edema along the hallux metatarsal head in the region of the sagittal band. But what I don't see is an extensor hallucis brevis full thickness tear that's retracted. And what I think about this case is that the extensor hallucis brevis, where it attaches to the dorsal hood, is partially torn with sprain of the sagittal band on that side, on both sides, and there's some edema in the hallux metatarsal head. What I suggest is that we do better imaging in this location to really understand what we're seeing. Again, there's joint effusion. This is the region, just to go through the turf toe portion of this case. We're looking at the sesamoids to the phalanx, so the sesamoidal phalangeal ligament. On the medial side, we do see that there's some edema along the region of the collateral ligament. We see on the fibular side, the sesamoid phalangeal ligament also intact. Joint effusion, no retraction. Looking at the axial images one more time, just to clear the other plantar plates, we're looking for U-shaped structures, and we can see that there's thickening along the second MTP joint. We can also see that in the region of the first intermetatarsal bursa, there may be a Joplin's neuroma. That's an enlargement of the first interdigital nerve in this location. And in the region of the plantar plate itself, we can see that there's some plantar capsulitis, some flexor tenosynovitis, and no detachment. So altogether, the positive findings that I think that we can definitely say are on this case is that there's dorsal capsular sprain, the sagittal bands are sprained, the extensor hallucis brevis, I believe that there's a partial tear based on the appearance of the way this is getting to the first MTP joint. I'm sorry, going the wrong way. Getting to its attachment in this location along the dorsal hood. I think there's a good amount of synovitis and there's a partial tear. I'm not sure what this is, but I would love to see repeat imaging with higher quality or post-contrast and be able to take another look at this. But irregardless of what we've seen here, the take-home we can review on this beautiful tutorial on first MTP joint anatomy. Just wanted to make sure that we all understand the structures that we're looking at so we can keep practicing. This is an example of the extensor hallucis longus and a tear of the sagittal band and a tear of the proper collateral ligament. And that's a clear indicate. You can really see the defects in this person who has what's called a skim border toe. We can see that this is the normal state here where we'd have very little signal along the extensor hood, and that's what I'm used to seeing. So there's definitely a problem in our case, but to what extent is it partially torn? I think the resolution of the imaging is not there. Here we can see this is a normal extensor hallucis, and we can see in this case I would have been calling sprain at the extensor hallucis brevis, where that's attaching here. They don't actually call that on this particular case. I just want to show a few more examples of, let me just go to the actual anatomy in this case. So the extensor sagittal bands, we're not really at that level here. Extensor, we see the extensor digitorum, the extensor hallucis brevis getting to the sagittal band. So that's what I would like to see. This, of course, these are high resolution imaging here, these high resolution structures seen here on these cadavers. We can see the extensor hood here, and here is where we really get to see the anatomy, the extensor hallucis longus, extensor hallucis brevis, and notice it's going to be attaching to the region of the sagittal bands and getting to the proper collateral ligament, accessory collateral ligament. Here we can see the extensor hallucis brevis attaching firmly to the proximal phalangeal base. And that's off to the side. That's over by the medial sesamoid. So we expect it to attach there. And here's in the midline, we can see the flexor hallucis longus. We can see the attachment to the proximal phalangeal base. And there is a slight gap, but I still think that it would have a firm attachment to the proximal phalanx. And getting to where we can see that on our case, we're seeing that synovitis in this location is abnormal for this patient. So hopefully we can get some better imaging. I hope that's been helpful. I'm sorry that it's not a perfect case, but I think it's based on the resolution and the state of the sprain that's occurring here, so it's poorly defined. Thank you. Hope you all have a good night.